Hello, my name is Simon.Noel. I am the Chief Nursing Informatics Officer at the Oxford University Hospitals NHS Foundation Trust. This presentation is looking at my area of study in relation to the way electronic records affect critical thinking in nurses and the way this influences the way we care for our patients. Some background about our trust. We are one of the biggest in the country. We're part of the Shelford Group. But most importantly, we are digitally mature. We are paper light in most inpatient areas, and we have a comprehensive nursing documentation process in the majority of our adult inpatient areas. So does the use of an electronic health record system facilitate effective critical thinking in nurses? If we look at the way digital has been working in NHS, it's a bit of a checkered history. Most NHS institutions are late adopters, but exception to this is probably primary care, where GP surgeries have been using electronic systems for a number of years. In the early 2000s, we had the National Programme for IT, which sought to try and kickstart the process, but this stumbled. However, trusts such as our own are still legacies from that particular first go at the digital programme. However, the government decided to try and reinvigorate digital within the NHS through the IT for Better Care report in 2015, and this was further supported by the WACTA report in 2016, which recommended the formation of the Global Digital Exemplar Programme and also posts such as my own. Digital has been fundamental to the 5-year forward view, and as a result, our professional institutions have been seeking to improve digital literacy across the country. In order to look at what had been published on this subject, I undertook a literature review, and looking at electronic health records, I got about 37,000 results of different papers. So filtering this down to do specifically nursing processes and improving supporting the process, and also then narrowing the search down to the 10-year period up to 2018, I ended up with 20 articles, most of which came from outside of the UK, by the way, America, Scandinavia, mainland Europe, but there were 4 clear general themes encountered. These themes are systematic patient review, nursing diagnosis, the advantages of electronic systems over paper, and the role of clinical decision support. If we look at systematic review, existing robust standards of nursing engagement and leadership were seen as imperative by most people who cover this area. Clear standards of assessment can be engineered in, and this then allows for audit and oversight. But appropriate design of the solution and the structure of interaction with it can inform and influence decision making, both positively and negatively, based on whether the solution has been structured appropriately. But effective sharing of care and diagnostic data was seen as being a real advantage, as multiple professionals can interact with the system. The appropriate and careful choice of a nursing model was seen as enhancing the design process, and also enhancing both decision making and also critical evaluation of the patient. But a nursing voice at the design stages was essential to make sure that the model was implemented appropriately and structures and designs were appropriately implemented. Nursing diagnosis. So effective design can offer relevant information at the appropriate time, and this can greatly influence the way nursing diagnosis is undertaken. However, the way in which this is done requires continuous review and robust oversight, and this needs to be built into the normal operational processes. Now, this review needs to be of the content, but also the way in which it's being used. Reinforcement of a standard nursing language across the organisation was being seen as ultimately beneficial, and one of the languages most frequently referenced is Nanda. Ownership and adoption were seen as vitally important, so the inclusive design process would help foster ownership and adoption, which means that the design of the solution was being seen as being not being enforced upon the nursing workforce, if you like. Most importantly, flexing the function to the user would help ultimately with specialist nurses, for example. So consultant nurses could get a slightly different view to, say, nursing associates, but the same information would still be presented, but just in a slightly nuanced way. So the advantages of electronic systems over paper were quite fundamental, and they're pretty obvious in most part. So the availability of information at multiple places, the facilitation of interprofessional working, and the avoidance of information silos was seen as being a real benefit, because it means that there's better communication between different teams, both nursing and otherwise. Continuity of access to the record meant that you wouldn't need to go back to the nursing Cardex, for example, all the time in order to get the information you needed. And transparency over security was also seen as being a real benefit, because it meant that there was no hiding on who had accessed the record and when they'd accessed it, which meant that there was better confidence over the way in which patient confidentiality was maintained. And also, because the electronic systems can be programmed in a certain way, it means that timely notifications can be built into the process. And this is to do with things such as new results or changes to treatment, such as new prescriptions. With this in mind, clinical decision support helps to create and enhance this notification process by building in rules and alerts. So this can then take evidence-based processes and build active feedback to users. This can help raise awareness of overdue drugs, of assessments, but also other patient welfare processes such as news to and sepsis, where there has to be a proper workflow and a nuancing of the rule. However, this relies on timely and accurate data. So the data must be in the record in a certain way and in a certain order to make sure that these rules work effectively. So retrospectively recording observations, for example, can have a great influence on the way these rules work. Over-engineering of these clinical decision support processes may be seen as an annoyance by some, and this is something which needs to be taken into great consideration when building an appropriate solution. And in the same vein, it's careful to build it in the appropriate way so this it's not seen as automating care, because if it does, then it can potentially undermine diagnostic confidence. So the relationship between these themes. So the reliable availability of information is obviously the bedrock of what we're trying to achieve. If this information is reliable and put in an appropriate way, clinical decision support rules can then be built in order to raise certain aspects of patient welfare to the fore. Systematic review can then be used in relation to the core data and the alerts to make sure that the patient is being managed in the appropriate way. And this then can facilitate nursing diagnosis. But there are some caveats on this. Effective operational system design is essential in order to make sure that the availability of the right information and the correct use of clinical decision support can be effective. But the effective support of nursing process is also fundamental to this. Having the right model, having the right process, and raising information in the appropriate way can have a direct impact on the way in which users manage and understand their patients. To this end, robust nursing leadership is fundamental to this process. The design of the solution will affect the nursing process. There is no doubt about that in my mind. Clear standards of documentation need to be in place before digital adoption can be effective. So you need to know what you're doing, you need to be robust in the way you're doing it before you can use the electronic system in order to enhance it. And robust processes and documentation standards can then be translated into the digital solution, which is why nursing voice and design has to be there from the get-go. So, does the use of an electronic health record system facilitate effective critical thinking in nurses? Looking at the evidence and in my opinion, yes, it can, but we need to remember the clinical record has moved on from being a flat record to a dynamic clinical tool, and it has changed. Digital is not a paper replacement, and this is often overlooked by users who implement these systems. This may be exacerbated on occasion by the view that electronic patient records are the remit of IT or technical teams. But the design of the electronic clinical systems cannot be the remit of the IT. They must facilitate it and not lead design. And as a result, the opportunity for professional nursing leadership to shape record is often overlooked. And this cannot be allowed to continue if an effective electronic system is going to go ahead. Some of the core considerations. So, to repeat myself, robust nursing professional leadership in the way the process is implemented is paramount, whether this be on paper or on a digital platform. The successful integration of nursing process and care standards relies on organisational buy-in from the planning stages. And guidance provided by electronic systems should inform and not lead care, so careful integrated design is essential. And the use of the electronic record should be integral to nurse education and training so that it becomes the norm. So what the nurses are expected to do and what they're being taught cannot be separate items. So to be brief retrospective about our COVID-19 experience. So this reinforced the need for informed leadership, reformed nursing leadership. So decisions were made at a rapid pace, and in order for the right decisions to be made at a rapid pace, there needs to be good dialogue between the technical nursing teams, such as myself, and the operational nursing teams, such as our directors of nursing, in order to make the right decisions at the right time and know what effect they're going to have on direct patient care. Significant changes can be implemented rapidly. We had a complete COVID operational nursing workflow designed, built and implemented within 5 working days, so we were very prepared for our COVID response. That said, small changes have a big impact. So one of the things that we looked at was the influence of admission assessments on the patients. If you take an assessment away, an automated assessment, the assessment still resides, but if you take the reminder away, then the volume at which that assessment is completed can be reduced, and that will have a dramatic effect on the way the patients are treated within the organisation. But the digital record does allow for meaningful audit and organisational learning. So we can take the information, we can learn from it, and then we can feed that back to the users, and that mitigates the risk and mitigates the effect of these small changes to the operational nursing record. Thank you for your time, and I hope you enjoyed my presentation.